Yes, sir.
Good,
3, 2, 1, start.
a very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today we have a presentation on Wilms tumor, and this would be presented by our resident, Dr. Nihal Singh, and would be moderated by our faculty, Dr. Manoj Bamaniya. So I would request Dr. Nihal to kindly share his presentation.
Morning, respected teachers and everyone. Uh, Good morning, respected teachers and everyone. Today's topic of presentation is Wilms tumor. I am Dr. Nihal Singh Balawa. Topic is moderated by Dr. Manoj Bamaniya, sir. Wilms tumor or nephroblastoma. It is the most common primary malignant tumor of the childhood. It is the embryonal tumor that develops from the remnant of the immature kidney. Epidemiology: 6 to 7% of all childhood cancers. Incidence is 7 to 10 per million. More than 80% patients are diagnosed before their 5 year of age. Median age of presentation is 3 to 5 years, and median age of diagnosis is lower in the children with the bilateral Wilms tumor. Incidence is lower in Asian population and higher in the Black populations. Biology and genetics. Majority of the Wilms tumor arise from the somatic mutations. 10% children have congenital anomalies and syndromes. 5 to 10% tumors are bilateral and multicentric, and 1 to 2% are familial. Congenital anomalies associated with the Wilms tumor: cryptorchidism, duplex renal cortical system, horseshoe kidney, and hypospadias. These are the gene mutations present in the Wilms tumor. Uh, WT1 gene occurs because of the deletion at the chromosome 11p13. WT1 is necessary for the pediatric bud outgrowth, nephrogenesis, and normal gonadal development. It is associated with the beta-catenin mutations. WT1 is associated with stromal predominant favorable histology. Their precursor lesion is intralobar nephrogenic rest. Uh, Associated syndromes in WT1 gene mutations are Weger syndrome, Denny-Dress syndrome, and Fraser syndrome. VAGR syndrome presents with Wilms tumor, aniridia, genital anomalies, and mental retardation. Denny-Dress syndrome presents with male pseudohermaphroditism, renal mesangial sclerosis, nephroblastoma. It caused by the point mutation in the WT1 gene. Majority of these patients progress to the end-stage renal disease. Weger syndrome and Denny-Dress syndrome patients have bilateral tumors and are diagnosed at the younger age. Fraser syndrome presents with Wilms tumor, gonadoblastoma, male pseudohermaphroditism, and nephropathy. WTX gene, it is a tumor suppressor gene. Its location is on the XQ1.1. WT2 gene mutations occurs because of the loss of heterozygosity in the 11p15 in the 70% of the patients. Type 2 Wilms tumor is characterized by limited nephrogenic differentiation and blastema or epithelial type histology. Tumor develops at the later age and have heavier birth weight. Children have heavier birth weight. 20% are bilateral diseases presentation, and WT1 gene mutation is associated with the Beckwith-Whitman syndrome. Beckwith-Whitman syndrome presents with the macroglossia, nephromegaly. Nephromegaly is having greatest risk of developing Wilms tumor, hepatomegaly, hemihypertrophy, hypoglycemia, adenocortical neoplasm, and omphalocele. Most cases are of Beckwith-Whitman syndromes are sporadic, and 15% have inheritable autosomal dominant genetics. Risk of nephroblastoma in Beckwith-Whitman syndrome is 4 to 10%. Familial Wilms tumor occur in 1 to 2% of all Wilms tumor patients. They have earlier age of onset and increased frequency of bilateral disease. Other chromosomal anomalies associated with Wilms tumors are TP53 mutations, loss of 16q, and loss of 1p. Both are associated with the increased risk of tumor relapse and the death with poor prognosis. Screening in Wilms tumor patients. Screen is recommended when the Wilms tumor incidence is more than 5%. Screen is done for the look for the contralateral kidney after nephrectomy in Wilms tumor. USG surveillance is performed at the time of diagnosis until the 5 year of age with frequency of every 3 to 4 months. In Beckwith-Whitman syndrome, we continue surveillance till 7 years. Early detection can provide opportunity for the nephron sparing surgery because these children are at the increased risk of bilateral disease, but it does not improve the survival in these patients. And CT or MRI should be performed when USG demonstrated suspicion lesions. After screening, USG film showing the small USG and axial cut of CT showing the small Wilms tumor detected by the screening. Pathology, there are two types of the pathology in the Wilms tumor. One is favorable histology Wilms tumor that present in the 90% of the patients. In these favorable histology patients, it compresses the normal renal parenchyma and it forms the pseudocapsule composed of the atrophic renal tissues. These tumors are soft and friable and are more prone for the hemorrhage during the nephrectomy. Classical Wilms tumor histology presents as the undifferentiated blastema, variable epithelial differentiation, and the significant stromal component. Wilms tumor with predominantly epithelial differentiation have low degree of aggressiveness and majority are the stage 1 tumors. This histopathology slide showing the blastema, tubules, epithelium, and mesenchyma in the Wilms tumor. Anaplastic Wilms tumor, there are presence of three abnormality in the anaplasia: nuclear enlargement to 3 or more times the diameter of the adjacent cells, hyperchromasia of the enlarged nuclei, abnormal mitotic figure. They are rarely seen in the less than 2 years of child. They have resistant to chemotherapy, and the anaplastic Wilms tumor have poor prognosis even the tumor is apparent to the kidney, that is stage 1. Pathology after the preoperative chemotherapy. After preoperative chemotherapy, stromal and epithelial predominates and they found more often after chemotherapy. Plus, blastemal component responds very well to the chemotherapy, but persistent blastemal components after chemotherapy have a higher rate of relapses. International Society of Pediatric Oncology classifies tumor necrosis as a lowest risk after perioperative chemotherapy. Tumor with diffuse anaplesia and blastemal predominance after chemotherapy are classified as the high risk, and other consist of the intermediate risk group. Nephrogenic rest, they are the precursor lesion and most do not form the Wilms tumor. They can undergo maturation, sclerosis, involution, or complete disappearance. There are two types of the nephrogenic rest: perilobar nephric rest. These are most commonly found in the Beckwith-Whitman syndrome, and intranodal nephrogenic rest seen in the children with aniridia, Weger, and Denny-Dress syndrome, and other features associated with the WT1 gene. Preoperative evaluation in the staging. More than 90% patients are present with asymptomatic abdominal mass. The mass may be extremely large relative to the size of the child. 20 patient present with the gross hematuria. If patient present with the gross hematuria, cystoscopy and retrograde pyelogram are done at the time of nephrectomy to rule out the tumor extension into the collecting system. 25% present with the hypertension due to the elevation of the renal plasma renin level. It resolves after the nephrectomy. Fever, anorexia, and weight loss present in the 10% of the patients. CT axial film showing the rupture of the tumor. Patient presented with the acute abdomen showing the perinephric collection. Extension into the IVC and the renal vein present with the 10% of the patient, and patient present with the persistent varicocele in the supine position, hepatomegaly due to the hepatic vein obstruction and ascites. Atrial thrombus may manifest as the hypertension or congestive heart failure. Physical examination reveals firm, non-tender mass that classically does not cross the midline. Investigations: blood counts, liver enzymes, serum electrolyte, including blood urea, nitrogen, creatine, calcium. Coagulation profile is altered in this patient because of the acquired von Willebrand disease. So preoperatively, we give vasopressin to normalize the coagulation profile. Imaging has important role to confirm the contralateral kidney is functioning or not before performing the nephrectomy. Chest radiography is done and may show the lung metastasis. That is the most common site of metastasis in the Wilms tumor. Ultrasonography first study to evaluate the children with abdominal mass. It will demonstrate a solid nature of the lesion. Doppler ultrasonography is helpful to exclude the intracaval tumor extension that occurs in the 4% of the Wilms tumor but have lower sensitivity. CCT, abdomen, or MRI is preferred for intra-IVC extension. CCT or MRI abdomen pelvis with gadolinium done in all patients. CT scan is done to look the origin of the tumor, size, contralateral kidney involvement, lymph node involvement, invasion into the major vessels, liver metastasis, and chest CT is done to rule out the lung metastasis. MRI abdomen can reliably identify the extension of the tumor into the IVC. T1 weighted image shows the low signal intensity and T2 weighted image shows the high signal intensities. Staging system of the children's Wilms tumor according to the Children's Oncology Group. There are 5 stages in the Wilms tumor. Stage 1, tumor is confined to the kidney and completely resected. The renal capsule is intact and the tumor was not ruptured before the removal. No tumor's renal sinus extension is present, and there is no residual tumor. Stage 2 is extracapsular penetration, but tumor is completely resected. Renal sinus extension or extrarenal vessels may contain tumor thrombus or be infiltrated by the tumor. Stage 3 is residual non-hematogenous tumor confined to the abdomen. Lymph node involvement, any tumor spillage during the nephrectomy, peritoneal implants, tumor beyond the surgical margins, either grossly or microscopically, or tumor not completely removed. Stage 4 is hematogenous metastasis to lung, liver, bone, brain, and so on. Stage 5 is bilateral renal involvement at the time of diagnosis. Prognostic factors in the Wilms tumor. Most important determinant of the outcome is histopathology and tumor stage. Loss of heterozygosity of chromosome 16q and 1p is associated with the poor prognosis. Treatment of the Wilms tumor. Multiple randomized controlled trials are there to determine the therapeutic protocol. One is child oncology group that recommends primary nephrectomy followed by chemotherapy or radiotherapy. International Society of Pediatric Oncology group that recommends upfront chemotherapy followed by nephrectomy. And United Kingdom Children Cancer Study group that recommends biopsy followed by chemotherapy followed by nephrectomy. This is the current treatment approach for the favorable histology Wilms tumor by stage. Stage 1 or 2 favorable histology without loss of heterozygosity of 1p and 16q. Surgery is nephrectomy. Chemotherapy given is vincristine and dactinomycin. There is no need of radiation therapy for the stage 1 and 2 disease. That is tumor confined to the kidney or no residual tumor. Stage 1 or 2 with favorable histology with loss of heterozygosity to 1p and 16q. Surgery is nephrectomy. Chemotherapy, we add doxorubicin to the vincristine and dactinomycin. That is for 24 weeks, and there is no need of radiation in these patients. Stage 3 and 4, that is residual tumor at the time of resection or lung metastasis with favorable histology without loss of heterozygosity of 1p and 16q. Surgery is nephrectomy. Chemotherapy is vincristine, dactinomycin, and doxorubicin for 24 weeks. And radiation therapy given to the tumor bed or chest. Stage 3 and 4 patient have favorable histology. With favorable histology and loss of heterozygosity 1p and 16q, nephrectomy is given. Vincristine, dactinomycin, doxorubicin, cyclophosphamide, and etoposide is given for the 24 weeks, and radiation is given to the local tumor bed and the metastatic site. The current dose of the radiation therapy for favorable histology in Wilms tumor is 1080 centigary for the abdomen and 1200 gary for the lung. Post-operative radiotherapy started within 14 days of the nephrectomy. There is some evidence suggests that the stage 1 tumors with favorable histology with smaller size Wilms tumor that is less than 550 gram with tumor with favorable histology, there is no requirement of the radiotherapy after the chemotherapy, only nephrectomy suffices the treatment. COG protocol for the high-risk disease, that is anaplasia. If there is focal anaplastic stage 1 to 3 tumors and stage 1 tumor with diffuse anaplastic histology, nephrectomy followed by chemotherapy with vincristine, dactinomycin, and doxorubicin is given for 24 weeks followed by local radiotherapy. If histopathology shows focal anaplasia with stage 4 tumor, diffuse anaplastic histology with stage 2 and 3 tumor, treatment is same to the focal anaplastic stage 1, 3 and diffuse anaplasia stage 1, but we add cyclophosphamide and etoposide and carboplatin chemotherapy. Diffuse anaplastic stage 4 patients are more aggressive treatment is required. Nephrectomy followed by irinotecan, vincristine, dactinomycin, doxorubicin, cyclophosphamide, carboplatin, and etoposide plus radiotherapy. And chemotherapy is given for 24 weeks. Surgical consideration. Radical nephrectomy is done via the transperitoneal approach. Thorough exploration of the abdominal cavity to exclude local tumor extension and metastasis and peritoneal seeding. Formal retroperitoneal lymph node dissection is not recommended, but selective sampling of the regional lymph node is essential. Exploration of the contralateral kidney is no longer mandatory. Preoperative CT scan or MRI demonstrate normal kidney. The renal vein and IVC are palpated to exclude the intravascular tumor extension before vessel ligation. the adrenal gland and can be spared without increasing the risk of tumor spill or recurrence if it is not close proximity to the tumor. Extensive lymph node dissection, particularly above the renal hilum, can result in the callus ascites. After surgical removal, there are certain risk factors for the local tumor recurrence, that is Schamberger's criteria. The recurrence is more in patient with tumor spillage during nephrectomy. If histology comes out to be the unfavorable, incomplete removal of the tumor, and absence of any lymph node sampling. In child's oncology group, we do primary nephrectomy, but in certain situations, we give preoperative chemotherapy. Preoperative chemotherapy recommendation according to child's oncology group. Children for whom renal sparing surgery is planned. Tumor is inoperable at the surgical exploration. Tumor extension into the IVC above the hepatic vein and bilateral tumors. In these conditions, we give preoperative chemotherapy followed by primary surgery. Inoperability should not be based on the preoperative imaging studies, which can overestimate the local tumor extension. If unresectable, pre-treatment with chemotherapy reduces the bulk of tumor and renders it resectable. Majority of the reduction occurs in tumor volume in first 4 weeks of the therapy, but reduction extends out through the 8 weeks. International Society of Pediatric Oncology Protocol, it recommends upfront chemotherapy followed by surgery. Benefit of this protocol is that tumor shrinkage reduces the risk of spillage, renders tumor resectable. We can do nephrin sparing surgery after the chemotherapy. For low-risk tumor, that is stage 1 tumor, vincristine adriamycin given for the 4-week and vincristine adriamycin, tectinomycin, carboplatin plus etoposide given for the 6 weeks for the high-risk diseases. There are significant fewer complications in those undergoing delayed nephrectomy performed after the 6 weeks of the chemotherapy. Repeat imaging is performed after 6 weeks of the chemotherapy. After adequate shrinkage of the tumor, definitive resection can be completed. CT film coronal section shows the large Wilms tumor. After 6 weeks of chemotherapy, there is significant reduction in the size of the Wilms tumor. Bilateral Wilms tumor. Recommendation for the bilateral Wilms tumor is preoperative chemotherapy, that is current child oncology group protocol. Tumor response is assessed after 6 weeks with CT or MRI to determine the reduction in the tumor volume and feasibility of the renal sparing surgery. Tumor not responding to the therapy requires bilateral open biopsy to determine histology and additional chemotherapy based on the biopsy. We do bilateral biopsy because anaplasia is found to be discordant between the 2 kidneys in 83% of the patients. So different kidney requires different kind of chemotherapy. We proceed to the surgical resection within 12 weeks of the starting the therapy. There is no benefit beyond the 12 weeks. Kidney with the lower tumor burden is addressed first. CT Excel film showing the near normal volume of the bilateral kidneys after nephron sparing surgery in bilateral Wilms tumor. Tumor enucleation should be done for the large centrally located tumor because in these patients, partial nephrectomy with normal renal margin may hamper the vascularity of the kidney. Bilateral radical nephrectomy and dialysis are rarely required when tumors fail to respond to the chemotherapy or radiotherapy. In these patients, anephric patient, renal transplant should be done after 2 years to ensure patient does not develop metastasis. Partial nephrectomy for unilateral tumor. There are certain conditions there where we can give partial nephrectomy. In syndromic patient, likely have smaller tumors and more amenable to the renal sparing surgery. Most Wilms tumor are too large to diagnosis to allow the partial nephrectomy. After preoperative chemotherapy, partial nephrectomy can be performed in the 10 to 15% of the patients. The lesion should be completely excised with a margin of renal parenchyma. Patient should not undergo partial nephrectomy if tumor cannot be removed at stage 1. Patient with high-risk histological features such as anaplasia or persistent blastomal predominant tumor after chemotherapy should be treated with complete nephrectomy. Late effects of the treatment of the Wilms tumor, fertility and pregnancy. Hypogonadism and azoospermia occur because of the radiation. Severity of damage depends on the dose dependent. Leydig cells are more radio-resistant, but higher dose can lead to the delayed sexual maturation. Chemotherapeutic agents adversely affect the testicular functions. Pelvic radiation exposure to alkylating agent can lead to the ovarian failure and premature menopause. Offspring of irradiated female, there is a risk of low birth weight and premature birth. Second, malignancies. There is 1% cumulative incidence at the 10-year post-diagnosis. Incidence of leukemia highest during the first 5 years of the treatment. Follow-up. Immediate post-operatively, patient must have the following monitored: blood pressure, electrolyte, temperature and blood glucose level, urine output. Follow-up visits for the Wilms tumor are usually scheduled every 3 months for 2 years after diagnosis, then every 6 months for another 2 years, then once every 2 years. Follow-up visits for Wilms tumor may include clinical examination of the abdomen for sign of any local recurrence of the or a liver tumor, clinical examination for lungs for any signs of metastasis, neck examination for thyroid nodule if the child had radiation therapy to the chest, breast examination in female patient who received radiation therapy to the chest, check for the peripheral neuropathy as we give vincristine therapy to these patients, check for the liver or veno-occlusive disease in patient with right-sided tumor who received radiation therapy. Tests are the part of the follow-up care. These will include abdominal ultrasound yearly is recommended. If abdominal ultrasound shows solid lesion, then we should do CT scan, MRI, chest X-ray to look for lung metastasis and liver function test, renal function test, early screening for infertility, hearing test for patient who received carboplatin, cardiac function tests such as echocardiogram or electrocardiogram at least every 3 years for patient who received doxorubicin. Early screening for colon cancer in patients who received abdominal radiation should start 10 years after radiotherapy treatment or by age 15, whichever is later. After lung or chest irradiation, the following is added: thyroid stimulating hormone and free thyroxine to monitor thyroid function. Thyroid USG is recommended every 3 years to screen for thyroid nodules and masses. Wilms tumor versus neuroblastoma. Neuroblastoma present as the younger age group, less than 2 years of age. Wilms tumor patient present with a slightly older age group, that is peak incidence is 3 to 4 years of age. Neuroblastoma presents with painful abdominal mass. Wilms tumor present as painless abdominal mass. In neuroblastoma, there is calcification is very common. Calcification is uncommon in the Wilms tumor. Neuroblastoma are poorly marginated that may extend into the chest. Wilms tumor are well circumscribed, close sign as it arises from the kidney and compresses the surrounding renal parenchyma. Neuroblastoma encases vascular structures but does not invade them. Wilms tumor invades the vascular structure with extension into the renal vein or IVC. Neuroblastoma child is usually irritable child, and Wilms tumor child are happy child. They are present with asymptomatic abdominal mass. Neuroblastoma origin is suprarenal and Wilms tumor origin is renal. Neuroblastoma metastasis most common site is bone marrow, liver and lungs. Most common is bone marrow. Wilms tumor most common site is lung, followed by lymph node. Wilms, this CT scan film showing the right side Wilms tumor that is renal in origin and showing the close sign because of the compression of the renal parenchyma. It does not process the midline. Neuroblastoma is suprarenal or extrarenal origin. It processes the midline and does not show the close sign. Thanks.
Thank you, Nihal. Good presentation. So I think we can take some comments from our experts. I see Dr. Bhatt who has joined us, and any other expert, Dr. Chandra or Dr. Gyanendra or Dr. Ansari, if there, please unmute yourself and give your comments. And there are a few people from abroad also who have joined us and from other parts of the country. If they have any comments, please let us know. So, Dr. Bhatt? Yes. Yeah.
Good morning,
Thank you.
everybody.
Good morning. Good morning.
Thank you. I think he has summarized well. There are only the first thing which I want to tell the residents is this is the indication of a CT in children before the age of 5. If there are tumor, and especially women, if you don't get all information with the MRI with the excretory dye, then this is one of the indication. But well-defined management, if you go with well-defined management, the prognosis is much better. This is what the approach is. I think it's almost decided with the indications of chemotherapy, indications of radiotherapy, surgical excision, margins, everything are well defined as well as a follow-up. Thank you very much.
Thank you, Dr. Bhatt. So if any of the faculty or residents has any comment to make, we have Dr. Nachiket, the Senior Professor, Urology. Welcome, Dr. Nachiket, please.
Thank you, sir. Sir, I just joined. I was a little late. I apologize. So he presented very well. The differences in between neuroblastoma and Wilms tumor are often asked inside the exams if you get a pediatric case. I think a few things that you missed is that subcutaneous nodules are more common in neuroblastoma. Wilms tumor does not present as subcutaneous nodules. And there was an interesting, thing which is written in books is that there is a term which is known as blueberry muffin baby. Blueberry muffin baby is basically on account of the subcutaneous nodules that occur inside neuroblastoma when they go in stage 4. You blanch those nodules and they become blue in color because on account of catechol being released. So that is one. The other thing is that neuroblastoma will present with retroorbital metastasis. So on other common site of metastasis, so they present with raccoon's eyes. This is a raccoon will present. Neuroblastoma also presents with epistaxis. So neuroblastoma, the epistaxis causing bleeding, is known as asthenia neuroblastoma. And then they can present with paravertebral symptoms also. So if you look at the detailed difference in between neuroblastoma and Wilms tumor, this is very commonly asked in the exam. It's because just by clinical examination of all these things and the pattern of metastasis, you can identify whether it's Wilms. And secondly, Wilms tumor is always smooth. Inside the CT scan, you fail to mention that it is smooth. Whereas clock ka bataya tha na, is bosselated, irregular. You can see those nodules in a neuroblastoma. But these are 4 or 5 things that.
Thank you, Nachiket. Good points made. Yes, the difference between neuroblastoma and Wilms tumor is very important. Not only the age, the type of tumor. Neuroblastoma can cross the midline. Wilms tumor usually doesn't. Yes, Wilms tumor usually have a pseudocapsule, and neuroblastoma actually may be infiltrating into the tissues. So again, yes, a very important point made around blue muffin syndrome, the subcutaneous nodules, and the brain metastasis that can occur in neuroblastoma. Yes. So if anybody has any other comment to make, we will take it. Otherwise, I'll just briefly summarize. There's nothing much to summarize. And then we will take up the MCQs. So Wilms tumor, Wilm was named after, Wilms tumor was named after Dr. Max Wilms. He was a German physician. And in 1899, this was named as Wilms tumor. And we all know Wilms tumor is the commonest pediatric abdominal tumor, right? And clinically, they present, as he said, usually most of them would present as asymptomatic abdominal mass. The other presentations could be hematuria, it could be pain, it could be fever. Hypertension is present in 1/3 of these patients. And usually these hypertension would recover after the treatment. And then they could be fever, anemia. So all these features can be present in patients of Wilms tumor. Investigations, definitely all the blood investigations. And here the CT scan is very important, not only of abdomen, but chest also. Lung metastasis is very common in Wilms tumor. Most of these patients would require CT chest also. MRI would be optional. If you need to find out the extension in the IVC and all those, then probably MRI can help you much better. Cytogenetic studies, again, in Wilms tumor has a role to play, particularly seeing the loss of heterozygosity in chromosome 1 and 16 and 11, and finding out those genes of WT1 and T2 and WTX. So all these are important. Plus, there is a role of biopsy, preoperative biopsy also. So again, the management, there are different schools. Most of them agree that doing a nephrectomy first and later followed by chemotherapy and or radiation, right? So, so there is again a school of thought which will give a neoadjuvant chemotherapy first followed by surgery. I think that's again, you also do a risk stratification to try to find out whether this is a favorable histology or unfavorable histology. And depending upon the tumor extension and the type of histology, the management will depend. I think that's all about. If anybody else has any other comment or make, we will go to the MCQs, please. Yes. So this was the first question is a 3-year-old boy had a hypospadias repair and orchidopexy as an infant and now develops renal insufficiency. Renal biopsy is consistent with membranoproliferative glomerulonephritis. Appropriate management before renal transplant is BCUG, gonadal biopsy, observation, bilateral nephrectomy. So this probably is not included in Wilms, is it? Has it got any relation with it? Glomerulonephritis. It's not nothing. It's not Wilms. No, but there has to be Wilms tumor, is it? But okay. Anyway, so what do you think? The answer is so yes. So all these patients who have membranoproliferative glomerulonephritis after transplant may develop again disease. So you do a bilateral nephrectomy. Yes,
the
please.
reason for bilateral nephrectomy is that they persistently cause hyperproteinemia.
Okay.
Early membranoproliferative glomerulonephritis in children cause persistent hyperproteinemia and long-term complications of
yes. So because these patients may produce, as Dr. Nachiket made the point that they may develop hyperproteinemia, they develop proteinuria and hyperproteinemia. So after transplantation, also these things may continue. So doing a bilateral nephrectomy is the right choice, right? So a newborn is identified with Beckwith-Widman syndrome. A renal ultrasound is obtained. The clinical finding that best predicts the risk of subsequent Wilms tumor development is hepatomegaly, hemihypertrophy, nephromegaly, and mutation at chromosome 1p. Anybody else? So Beckwith-Widman syndrome. Is it nephromegaly? Why do you think so?
Nephromegaly has the highest risk of prediction for the Wilms tumor in Beckwith-Widman syndrome. Apart from these symptoms, patient present with the nephromegaly, there are chances of development of the Wilms tumor is higher. Sir.
Okay. So there are various syndromes which are usually associated. So Beckwith-Widman is one of them. Dennis-Dress is another. Fraser another. Wagner syndrome is another. So I think it's very important when you examine these patients whether they belong to some of these syndromes or not. 6-month-old girl diagnosed with aniridia, USG done every 3 months. This will result in increased survival, detection of lower stage renal tumors, decreased incidence of bilateral tumors, decreased surgical morbidity. I think these patients may detect a lower stage renal tumors, right? Because they already is an iridia, they may be a part of that syndrome. So early detection of the low stage tumors can be picked up on ultrasound. I think yes. Yeah, pardon? Yes. So the main thing is whether we can pick up, because earlier ultrasound is not showing during infancy, but as you do other ultrasounds, serial ultrasounds, you can pick up these tumors and can start management early. So a 1-year-old boy undergoes nephrectomy for Wilms tumor. The finding that has most adverse impact on survival is hilar lymph node involvement, renal sinus invasion, capsular penetration, ureteral extension, and renal vein thrombus. So it is a lymph node metastasis. Lymph node metastasis is definitely, I think, has an adverse impact because all the rest are a local extension only, right? So hilar lymph. 4-year-old girl undergoes nephrectomy for favorable histology without loss of heterozygosity of 1p and 16q Wilms tumor. Imaging reveals multiple pulmonary mets treatment should include. So this is a favorable histology, Wilms tumor with lung mets. Observation, resection of pulmonary lesions, chemotherapy with chest irradiation, only chemotherapy, doxycycline. I think yes. So she should be given a proper chemoradiation. So chemotherapy, proper dose, along with chest irradiation. That should be the treatment. Yes. 5-year-old girl presents with hematuria. CT reveals right abdominal mass with extension of tumor thrombus into suprahepatic vena cava. Next best step is chemotherapy, irradiation, palliative management, primary surgical removal of kidney and tumor thrombus. It is going suprahepatic. So one of the indications for neoadjuvant chemotherapy is a suprahepatic IVC thrombus. So those who do even nephrectomy followed by chemotherapy, here one of the indications for neoadjuvant chemotherapy, first or upfront chemotherapy is this, I think. Yes, chemotherapy. 2-year-old boy is found to have bilateral Wilms tumor occupying more than 50% of the left kidney and 4-centimeter tumor in upper pole of right kidney. Next best step is left nephrectomy, right renal biopsy, bilateral partial nephrectomy, right partial nephrectomy, and left renal biopsy, bilateral nephrectomy is chemotherapy. Again, same. So bilateral renal tumors are stage 5 disease. So anything 3, 4, and 5, chemotherapy is the treatment of choice before going for surgery. So upfront chemotherapy is the treatment. A 3-month-old boy undergoes removal of a 300-gram Wilms tumor of right kidney. The pathology shows diffuse anaplasia and tumor confined to the kidney. Lymph nodes negative. Next step is observation of vincristine dactinomycin, and irradiation to the tumor bed and chest, and chemotherapy and irradiation to tumor bed. Pardon? D. Anybody else? So D. Yes, because the tumor, though it is less than 550 gram, but still it shows diffuse anaplasia. So chemotherapy plus irradiation is the choice. To tumor bed, not to chest. Why should you give to chest? Right, D. 1-year-old boy undergoes removal of 420 grams of Wilms tumor of right kidney. Pathology shows favorable histology without loss of heterozygosity of 1p and 16q and tumor confined to the kidney, lymph nodes negative. Next best step is observation, chemotherapy, irradiation, chemotherapy, and irradiation. So again, favorable histology, tumor less than 550 grams. Usually, if it is more than 550, it changes the treatment. Plus, there is no loss of heterozygosity. Plus, no lymph nodes positive. So, chemotherapy to hai, but I think observation can also. This is one of the, I think, kind of a scenario where you can observe the patient also. So, observation may be given, particularly when there is a favorable less than 550 gram of Wilms tumor, no heterozygosity, and no local extension, no lymph nodes involved. One. Less than 2-year-old child. Okay, good. So I think we'll stop sharing it. If anybody has any comment to make, otherwise we will ask the moderator, Dr. Manoj, to kindly wrap up the session. We do not have anything on chat box. Dr. Ashfaq has joined. Dr. Mar Betki, I think is from abroad. So anybody wants to make any comment? Dr. Bhatt wants to make any last comment? Otherwise, we'll wrap.
No,
Yes,
thank you.
Dr.
I think winded up nicely.
Thank you, sir. Thank you. So, Dr. Manoj, please come.
Thank you, Nihal, for good presentation, and thank you for the valuable information.
So thank you once again, all the residents, all faculty members, all those who have joined us today on YouTube and Zoom. Thank you very much and have a good day.